Hello, everybody. My name is Markus Möhlenbruch from Heidelberg, Germany. And as you can see here, the topic of my talk is the Heidelberg experience with the fourth generation pipeline Vantage with Shield. But it's not only a Heidelberg experience, actually, it's a multi-center experience. So here you see my disclosures. So when we discuss the pipeline Vantage, here you see a direct comparison to the pipeline Flex. So as you probably all know, the Flex consists of cobalt chromium wires for the implant shape memory and of platinum wires for the implant visibility. Whereas the pipeline Vantage, which is a completely new design flow diverter, is composed of DFT wires with a cobalt chromium shell and a platinum core, and 16 solid cobalt chromium wires. And if you look on the pictures, you see that the visibility of the Vantage, for example, is much better, much clearer compared to the pipeline Flex. Furthermore, if we look to the different microcatheters which are necessary for the deployment, you see that the smaller sizes of the Vantage, like 2.5 up to 3.5, are compatible with an 021 microcatheter system. The larger diameters, so 3.5 up to 6 millimeter, are compatible still with an 027 microcatheter system. But with the Vantage, there are two new additional diameters available, 5.5 and 6 millimeter compared to the pipeline Flex. There is another important feature, which is the number of wires. So larger diameters of the pipeline Vantage consists of 64 wires, whereas the pipeline Flex is composed of 48 wires. And the higher number of wires increase the relative pore density and maintain the metal surface coverage, especially if you treat larger diameters like 5 or 6 millimeter compared to smaller diameters where you have usually a higher rate of metal surface coverage. So the pipeline Vantage, of course, has the same or similar shield technology like the pipeline Shield in order to improve the hemocompatibility and the deliverability. So we looked at 10 international neurovascular centers and analyzed the patient and aneurysm characteristics, the procedural parameters, complications, and the grade of occlusion. So 61 patients were treated with a pipeline Vantage with an overall number of 71 aneurysms. Almost 5% of the aneurysms were treated in acute stage of SAH, and more than 90% of the aneurysms were located in the anterior circulation. 82 pipeline Vantages were implanted in 62 treatment sessions, and the pipeline Vantage could be successfully implanted in all but in one of the treatments, so the rate was 98.4%. An additional coiling, and this was the reason or the case in large aneurysms or in aneurysms with irregular shape, was performed in almost 20% of the cases, and an in-stent PTA was performed in almost 25% of the cases in order to enhance the vessel wall apposition. But in some of the centers, in almost all cases, a PTA was performed. So here you see the rate of the symptomatic complication, which was 8.2%, and this includes a groin hematoma, urinary tract infection, or a contrast agent allergy. But the neurological symptomatic complication rate was very low. It was 3.3%. So we had one patient with an device-related complication. This was a minor stroke caused by a perforator artery infarction. And we had one patient, but this I think was not related to the device itself. It was related to the fact that this patient was treated in an acute stage of SAH, and unfortunately the patient died due to vasospasms. So after a mean follow-up time of 7 months, the rate of complete aneurysm occlusion was almost 78% of the cases. So here you see one example of an ACOM aneurysm, which was treated in 2016, and 5 years later, you see a reperfusion, and we decided to treat this reperfusion by an additional coiling and the use of a pipeline. So here you see the final run with, I think, a good result, and you can see on the DynaCT the nice opening of the stent. 12 months later, you see here the MRI follow-up. This is a time-of-flight imaging. I think you can see the perfused lumen of the stent, but of course, it's not possible to decide if there is something inside or not. So that's why we performed an additional DSA control. And again, here you see that the flow diverter Vantage is nicely perfused with a complete occlusion of the aneurysm. Here's another case, 22 years old female patient. She presented with diplopia caused by this almost giant ICA aneurysm. Due to the size of the aneurysm, we decided to treat this aneurysm with a Pipeline Vantage and additional coiling. Here you see already the microcatheter in place for the Vantage and an additional microcatheter for the coiling. So the Pipeline Vantage was deployed. This was a very long version, 5x40. You can nicely see the opening of the stent and the nice visibility, especially in the lateral view. After complete deployment of the Vantage, an additional coiling was performed. This is the immediate result afterwards. And in this case, again, 12 months later, we performed a control DSA, and you see that the aneurysm is nicely excluded. I think there's almost a complete occlusion of the aneurysm in this case. So here's another example of a patient, and this patient presented in a different institution with a CCF fistula. A couple of weeks later, we repeated the DSA in our institution, and we figured out that the CSF was occluded over time, but that there was an aneurysm which was not visible before. So we decided to treat this aneurysm by the use of the Pipeline Vantage. So here you see, again, the deployment of the Vantage. In this case, there was a gap between the mesh or the stent and the outer surface of the vessel in the proximal part of the Vantage, and this was visible still after an internal massage. So we decided to perform a PTA afterwards, again with a good result, and this is a 12 months follow-up with a complete occlusion. This is the last example of an SCA aneurysm, which was treated by Professor Czekirch. And again, you see after 6 months, a nice remodeling and occlusion of the aneurysms. And here's an MCA bifurcation aneurysm, which was treated with a Vantage in the inferior trunk of the MCA. And again, after 6 months, you see that the aneurysm is completely occluded and you see a nice remodeling of the bifurcation. So in conclusion, the new Pipeline Vantage flow diverter is safe and feasible for the treatment of intracranial aneurysms. The short-term occlusion rates are promising, but there is, of course, a need for further assessment and prospective long-term follow-up studies. I'd like to thank all the participating centers from Germany, from Turkey, from Finland, Spain, and Canada, and thank you for your attention.
Good morning. We're going to talk today about how catheter characteristics may influence the thrombectomy success. We know about the first pass effect and how additional passes may progressively worsen our outcomes. Still, recanalization after fifth pass is better than non-recanalization. Why is this happening? Why the same degree of recanalization leads to worse outcome? So we can get to a TK3 from several ways. We can go straight at the first pass from 0 to 3. We can fail the first, fail the second, and then have a sudden recanalization in multiple passes. This we call sudden recanalization. It means a compact clot, as opposed to those situations in which we have some kind of fragmentation with intermediate degrees of recanalization. This we call progressive recanalization that might be a marker of clot friability. And in fact, you see that the effect of the first pass effect doesn't come from the pass of from the effect of first pass recanalization, but from the fact that it's a sudden recanalization. If you can see, if it's sudden recanalization, even with first, second, or third attempts, it's the degree of good outcome is exactly the same. However, the bulk of sudden recanalizations occurred at first pass. So we need to avoid fragmentation as much as possible, and also we need to avoid clot rolling. This is what happens when you progressively pull your clot a long way over the arteries. It rolls and you may lose it at some point. So this is why it's a good idea to bring as high as possible your exit door that is going to be either your distal access catheter or your guiding catheter. So it's a good idea always to bring a navigable guiding catheter as high as possible. And the higher, the better, in my opinion. Now, we measured how different distal access catheters perform when we pull them through models. And you see these sudden tension releases that occur. We don't want to happen because, and we can measure them, in fact, and characterize them for each catheter. And we don't want them to happen because this is what happens. We might interact with the clot like this. We can fragment it and send it, embolize it. So what happens, in fact, when we progress with our distal access catheters is that initially there's some degree of compression at the tip when they encounter some kind of obstacle. And finally, there is what we call snaking. You accumulate tension that can suddenly be released. And this is, as I said, what we don't want to happen. And the different catheters will behave differently according to the coiling, the braiding, and the jacket that they have in their design. And for different catheters, we measured all these tension releases, and we can compare them, as I'm going to show you. Also, how can we reduce them? We can reduce these tension releases by navigating through a microcatheter. This will improve a lot the tension releases, as you're going to see here. And finally, to improve them even more, you can anchor the whole system with a stent retriever, and you're going to see that the tension releases in this case are going to be much, much less, and the progress is going to be much smoother. So we can compare the three strategies: DAC alone, DAC with microcatheter, or the three items combination, which will progressively decrease the tension releases. And we can measure it for different catheters, and you can see how each of these distal access catheters will behave differently according if you include a microcatheter and also you anchor with a stent retriever. The less tension release, the better, in my opinion. Now, what happens when we aspirate through a distal access catheter or a stent retriever? At some point, if we're clogging the aspiration, we're not exerting any negative pressure, and we might have this embolization because we're not protecting with reverse flow. The clot inside is clogging, so we are not aspirating. What we should do is continue to pull, and this is going to be like applying negative pressure with a syringe. Your clot is going to be the embolus of the syringe, and you should do your thrombectomy, as I'm showing here. While you progress your access catheter, you continue to pull, continuously pull, so you create constant negative pressure on all the fragments that you might be embolizing, like this one, is going to be ingested because you are aspirating with your negative pressure. Now, many times, keep in mind the following. So when we needed to extract a clot, a large clot, for example, at the terminal ICA, many times our exit door is going to be much smaller, and many times our clot is going to be, as you see here, not fully ingested. Now, we try to study the features of the catheter tips in order to see how the interaction with the clot can ensure a better ingestion. And we studied the distensibility of different aspiration catheters with this kind of clots, of conic clots that we aspirated with in this setting, as you can see here, and we measured what was going to be the detachment force needed to detach the clot. So what we expected to see was, according to the physics formula that you can see here, however, all the catheters behave better with higher detachment forces, and the delta force for one catheter was much higher than for others. Why is this? We tried to explain this, and to do that, we now put the the clot analog, but instead of aspirating, we just applied the pressure that we observed, the delta pressure for each catheter, in the other direction. So we measured what was the distensibility of the catheter tip. So now we had the effective inner diameter instead of the labeled inner diameter. And if you apply the formula with the effective inner diameter, you can see that all catheters are in the same line. So in fact, what drives the detachment force is the effective ID. So those catheters with more distensibility would have much higher effective IDs and better optimized forces to withdraw the clot. So thanks for your attention. I'm going to be very happy to answer your questions here. Thank you.
Welcome to a Medtronic Q&A session. My name is Kirill Primak and I'm marketing manager for Medtronic. I would like to welcome Professor Markus Möhlenbruch, Head of Interventional Neuroradiology of Heidelberg University Hospital, and Dr. Marc Ribo, Interventional Neurologist from Heidelberg Hospital in Barcelona. Thank you very much, Professor Möhlenbruch and Dr. Ribo, for delivering your scientific presentations. We have a few questions from the audience, and first question is to you, Professor Möhlenbruch. Thank you for sharing this multi-center experience on Vantage. And being one of the first Vantage users, what are your thoughts actually on the differences between the Pipeline Shield and the new Pipeline Vantage, and what do you see from your experience?
Yeah, thank you very much, Kirill, for inviting me and for the introduction. So if we compare the Vantage with the Pipeline Shield, so first, one important point is that the friction, the overall friction, is much lower when you deploy the Vantage compared to the Pipeline Shield. And this, I think, makes the whole procedure more safe because you need less power for the deployment. So the manipulation of the device is much easier compared to the Pipeline Shield, and therefore all the different push and pull techniques are not so important when you deploy the Vantage. Furthermore, another different feature is when you deploy the stent out of the microcatheter, usually the Vantage will open by itself, so it's not necessary to resheet again. So usually after a couple of millimeters, you will see that the device will expand, and then you continue, of course, in a slow fashion to deploy the Vantage. And at the end, with the, let's say, latest version, there is no problem of detachment from the delivery wire. So this works, at least in our cases, always compared to the previous one.
Professor Möhlenbruch, with the new sizes actually compatible with 021 segment, Pipeline is entering a new segment. What is your experience here? Do you see any change in the education in the current practice? And what are your feelings about this 021 sizes compatible from Vantage?
I mean, if we look to the smaller diameters, yes, I think if we like to treat smaller vessels, then of course it's helpful to use smaller delivery microcatheters. So yes, that's definitely an advantage over the old Pipeline Shield version. And the other thing is that we have larger diameters with a higher number of wires. So therefore, the hope is, of course, that even in vessels with a large diameter of more than 5 millimeters, we will have a good flow effect and a good result over time. But this is, of course, what we will see in the near future.
Thank you very much. Dr. Ribo, next question is to you. You talked a lot about distal tip distensibility of aspiration catheters. And when we talk about combination technique, do you think that distal tip distensibility is still relevant and important if you combine it with stent retriever?
Yes, sure. Listen, what we try to show with our experiments overall is how little things work and how by these little things we can improve our results. And I think it's very important to understand that the tip of the catheter, the more it adapts to the shape of the clot, the better it will seal the pressure, the better it will allow to swallow the clot. And this would be independent if you are using a stent retriever in combination or not. So this adaptability of the tip to the shape of the clot, I think it's really important. And again, no matter if you are combining with a stent retriever or not.
Thank you very much, Professor Möhlenbruch and Dr. Ribo, for your time today. And thank you, faculty, for hosting us today. It's a great pleasure for us to be here, and wishing you a great continuation of LINNC Live Talks.
My pleasure. Thank you.
Thank you.